Excuse me, please. All right, I will assume everyone is on board and we will begin now. Acute inflammation. If you think about inflammation, just think about war. Think about war. Think about, Russia and Ukraine. What happens is that there's an offense, there's an offending organism or offending trigger. And that trigger causes mobilization, and the mobilization occurs via, the airwaves or the airwaves, also the internet. It occurs through word of mouth. It occurs, through the railway, through the pipelines. The communication occurs through every other channel that is possible. And once there's communication, the next thing that occurs in war is movement. So there's communication, that is passage of information, but then there's movement. There's movement of the acts of war. So the vehicles will move, the vehicles, the different vehicles are going to move. They'll move through the waterways, the land, over land, and every other way they can move. And they'll all be attracted to the point of conflict. That is a point that they are required. And the point where they're required is through communication. So they're informed. The people are using drones. The drones are programmed to land at this particular point at this hour. And the damage that they are supposed to cause is already predetermined, right? So we are talking about acute inflammation as an act of war. And the purpose of acute inflammation usually is, one, to destroy. You're going to destroy. So you're going to kill and finish the offender. Number two, and I want you to remember that. Number two is to dilute. So you find those people, there are chemicals that have been released, for instance, in the air. So you need to dilute them or neutralize them. So that is the act of dilution. There is chemicals in the waterways. You need to dilute them. So there's dilution, there's destruction. You need to destroy. And as you destroy the enemy, you'll also anticipate to destroy some innocent people, because it may involve a bomb, and the bomb is not going to respect anyone, whether friendly or unfriendly. Destruction will occur. And finally, you dam it off. So the triple D of acute inflammation: destroy, dilute, and to dam it off. Dam it off is when an abscess is formed. Like in the human body, you form an abscess. You form an abscess because you have entrapped the debris, inflammatory cells, edema, and then you form a fibrous wall around that. And that fibrous wall ensures that the bacteria that are entrapped, and it's the same concept with a granuloma in TB and other granulomatous conditions. So you're damming off all that into one enclosure, so that the toxic people, the toxic organisms, the prisoners of war are put together so that they do not dislocate and translocate to go intermingle with the normal population and cause other unwanted side effects. So that's the reason why we need to dam it off. So the 3 Ds of acute inflammation is to destroy, dilute, and dam off. And I think our class technically is well understood and finished. We look a little bit at we have touched the introduction, but we'll go, because now you have a grasp of what it is. We'll look at the vascular and cellular events. The vascular is actually the conduit. We talked about movement. We talked about transportation. Transportation between point A and point B is going to be through the vascular system. Of course, the nervous system is quicker, it works. So there are many media, but we're going to look at the vascular response to acute inflammation. And also we are going to look at the cellular events that take place. So the cellular response and vascular response. You also will remember that these are the communication gadgets and transportation mechanisms. Then there are chemical mediators. This is also part of the information system, cellular information systems. These mediators are the ones that are going to attract the soldiers. They're the ones who attract the soldiers. So they'll guide the soldiers into where to land and what actions to do. And when the war is over, the chemicals will disappear. So the cells sending the chemicals will stop. Some chemicals are made to be short-lived. So if they work for 5 minutes, they work for 5 minutes. And once they disintegrate, no more chemical is released unless the body says so. As long as there is an offender, the chemicals are sent. The moment the offender is vanquished, you're not going to have any more chemical mediators released. And actually now they start the business of repair. So every time Russia crashes let's say the electricity system, the people in Croatia, not Croatia, but Ukraine, immediately zone off the area. They take away any remaining harmful explosives and start work of repair of that. So it's the same thing with the body. Take away the debris as you begin the repair process. So the aim eventually, the purpose of acute inflammation is to return the body system to the original pre-injury state. And then we have consequences. We have outcomes. The good outcomes are the ones that take us back to the normal. And when we have failed to take us to the original normal body system, then we can have healing with scar formation. At least you have some normalcy returned. And in that process, remember, then occasionally when we cannot take away all the offending, like microorganisms, some of them like fungus and bacteria may evade mechanisms of destruction, then we have a process of chronic inflammation ensuing. And apparently some chronic inflammations like the ova or schistosoma, if they are within the bladder, urinary bladder wall for long, they cause irritation, and eventually you can have malignancies coming out, like squamous cell carcinoma of the urinary bladder. Good. So to inflame is to set fire. Inflammation is a dynamic response to vascularized tissue to injury. So every time you have vascularized tissue being injured, there is a process of inflammation that ensues immediately. So it is by nature a protective response, but it is in itself also capable of causing some tissue damage. Acute inflammation or inflammation does not mean infection. Inflammation just means tissue destruction. It could be by many stimuli, as we shall see. So it is a transient and early response. That's why it's acute. It's transient early response to injury, and it's characterized by the two main components that we said. One is a vascular changes, which are initial vasodilatation, initial vasoconstriction, then a vasodilatation, which is sustained with accompanying vascular leakage of the constraints and activation of the endothelial cells. And this is where now you have interaction with the cellular components also. And the cellular changes are usually leukocyte emigration, activation, emigration, particularly the polymorphonuclear cells. And it suffices to say that these two reaction patterns, the vascular and the cellular, they are not unique. They are the same if it's a foreign body, if it's a virus, if it's a bacteria, if it's cold weather, if it's heat, any cause if it's trauma, any cause. And that's why we call it a stereotyped response. Any form of tissue damage, either infection or trauma or whatever it is, causes the two changes, vascular changes and cellular changes. And that's the important part. So what are the triggers? Infections, bacterial, viral, fungal, parasitic, otherwise. Trauma, blunt and penetrating. All these physical and chemical agents will cause tissue damage. Any tissue damage brings up acute inflammatory response. Tissue necrosis following ischemic process. Example is in myocardial infarction. The changes that occur there, they are the changes that we would have seen if there was bacteria inside. We look at foreign bodies, splinters, dirt, sutures. They will induce an initial acute inflammation. Immune reactions, also called hypersensitivity reactions, against environmental substances or against cell tissues. So these are the varied stimuli, but remember the response of the host. The response of the body is always going to be stereotyped. It's going to be vascular and it's going to be cellular. Are you guys present? I believe so. Clinically, there are signs of acute inflammation. And these were initially described, the four ones were described initially by Celsius in Rome, and later loss of function was added by another German gentleman. I think Mishikov something. So we have redness. So the first one, you're going to have redness of that zone. That's purely because of increased blood flow. Then you have swelling, which is called tumor. So tumor is the word for swelling. So tumor can be due to fluid or inflammation. It can be due to tissue growth. It can be due to cancer. It can be due to anything. Tumor just means a swelling. And in these aspects, we're dealing with tumor being represented by exudation of fluid. So it's the swelling of that zone. If it's in that joint, you're going to see like the knee swelling due to fluid accumulation in that space. Then you're going to have the area hot. So when the heat is what we call color or color. Color is due to increased blood flow, exudation of the fluid, release of inflammatory mediators. And number 4 is pain. The area will be painful, which is dolor, caused by stretching of the pain receptors and nerves by inflammatory exudates and also chemical mediators. So it's stretch receptors due to the injury. And 5th is loss of function, functionlessa. And this is due to number 1, the pain in that joint, that area will cause the subject not to be able to move it. There's also disruption of tissue structure where there's significant damage and injury. Later on, you may have fibroplasia or metaplasia of that tissue and loss of the normal function. So these are the famous 5 cardinal signs of acute inflammation. You should know what they represent using also the Latin type. So I may send you an MCQ asking tumor in acute inflammation, tumor or rubor represents what? And you need to say redness or heat or pain or functionless. We dive into the vascular changes. We have a transient initial vasoconstriction. This only lasts a few seconds. It's the same thing you'll see when you're dealing with hemostasis. Once a vessel is injured, the first thing you find is transient vasoconstriction. And this allows for reduced blood flow in that zone for the platelet plug to be able to form so that you don't have sustained loss of blood. That is followed by vasodilatation of the arterioles, which is mediated by histamine and other vasodilators like nitric oxide. Nitric oxide is very important as a vasodilator in the body. It's also shown that with increased age, as you get to our age and further, we lose capacity to generate enough nitric oxide. And that's why we may find that we have some issues with vascular flow. What vasodilation does is that it leads to increased blood flow and increased hydrostatic pressure in that zone. Increased intravascular pressure causes seepage of protein-poor fluid into the interstitial space. So increasing the hydrostatic pressure will allow or will push the protein-poor fluid, the transudate, into the interstitial space. And remember, this interstitial space is a place of interest because that's probably where, let's assume, is an infection. That's where the bacteria have entered. And reduced blood flow number 3, what happens is that we have a reduction in blood flow. How? Decreased hydrostatic pressure caused by the outflow of the fluid in the interstitial tissue increases the red cell concentration in that particular section of the body. And now the increased red cell concentration increases blood viscosity. Yes, there was increase in the vascular pressure caused by seepage of protein-poor fluid, causing transudation. Fluid goes, you have concentration of cells, a decrease in the pressure, and subsequently an increase in blood viscosity. This results in stasis that can be demonstrated microscopically as numerous dilated blood vessels filled with red cells. Okay. And these are redness. So there is increased viscosity. The cellular elements are increased because you basically have lost the fluid component. You lose a fluid component, you have a higher concentration of the cellular components in that part of the vessel. So these are normal. And here you have arteriolar dilatation. You have expansion of the capillary bed and venular dilatation. So at this space, you're going to have what? More loss of fluid, leakage of plasma, leakage. You're going to have more leakage of fluids, and then later you'll have leakage of plasma proteins, leading to protein-rich exudate. This zone is also where you're going to have more escape of immigration and accumulation of white blood cells, but the polymorphonuclear leukocytes. So you have dilatation, we have transudation, then as you get transudation, later you get protein leakage, protein-rich, plasma protein-rich leakage, you have edema, and also the cellular components leak. Good. So initially, it's the same thing we are talking about. You have normal status, you have fluid leakage, you have fluid and protein leakage. Subsequently, in the process, you also get to have increased interendothelial spaces, interendothelial spaces opening or widening. So widened spaces will allow more protein-rich exudate to get out and more tissue edema. Why do you get vascular leakage? One, the endothelial cell contraction leading to intercellular gaps in postcapillary venules occurs. It follows binding of histamine, kinin, leukotrienes to specific receptors, and this lasts for about 15 to 30 minutes after the initiation of the triggers. Cell retraction, or the endothelial cell retraction is mediated by cytokines, specifically tumor necrotic factor and interleukin-1. And it's slow in action and works also up to 4 to 6 hours. It lasts 24 hours. Causes cell cytoskeletal reorganization so that you have retraction of these endothelial cells. Severe endothelial injury can occur and does occur, leading to vascular leakage by causing endothelial cell necrosis and detachment. This is associated with thermal injury, and it's leukocyte mediated. Yeah. When you have severe thermal injury, you tend to have severe endothelial cell damage and necrosis. So once the cells are necrotized or they're dead, then you're going to have the spaces exposed and the cells are going to ooze outside that body. You have increased, point 3, increased transcytosis of proteins. Vascular endothelial growth factor mediated intracellular vesicular travel from luminal to basement membrane of the venules. So from the lumen through the basement membrane, so you have escape. And this is mediated by VGEF. And this escape of proteins. Vascular leakage is what we're discussing. And finally, leakage from new blood vessel lacking tight junctions. So you also have vasculogenesis in the process. And when you have vasculogenesis, the cells are not having tight junctions yet as the vessel wall is still forming, and you have also sustained leakage during that time. We have a role of lymphatics, we know very well. Their business is to mop up any excess fluid in the extracellular space. And it also mops up leukocytes and cell debris from that space. Transport of offending agents may lead to inflammation of the lymphatics, and you get lymphangitis and the draining lymph node lymphadenitis. And inflammatory lymphadenitis, we have swollen and tender lymph nodes secondary to hyperplasia of the lymphoid follicles and increased numbers of leukocytes and phagocytic cells lining the sinuses of the lymph nodes. And everyone, if you've ever gotten some little trauma on the lower foot, you get to notice that the inguinal nodes may get tender and painful and enlargement due to the inflammatory process. So those are the vascular events. We look at the cellular events. And the vascular events, we can summarize them as initial vasoconstriction. Then we have vasodilatation, which is sustained by histamine, nitrous oxide initially, and then leukotrienes. After that, then you have leakage initially of protein poor, then you have exudation, protein rich, then you have extravasation now of the cells, but that's where we are now. Leukocyte recruitment and activation. Recruitment of polymorphonuclear leukocytes involves 1, margination and rolling along the vessel wall. Then we have firm adhesion to the endothelium. After firm adhesion to the endothelium, then they transmigrate through the vessel wall and migration in the interstitial tissues towards a chemotactic stimuli. These are the drones we talked about. We talked about drones being directed to the point they are needed. So they'll migrate towards the chemotactic stimulus. Where the most stimuli is coming from, that's where they are attracted to, and that's where they are going to disembark. Initial point is margination, aligning along the margin. Following increased vascular permeability, fluid leaves the intravascular compartment. We saw that. The RBCs aggregate into rouleau, and the neutrophils are pushed from the central axial column to the periphery of the vessel. Normally, when you have luminal flow, you have fluid at the sides of the vessel wall, and the cells are usually at the center. Now you have fluid loss and stasis. Fluid loss and stasis. So the cells are going to navigate, they're going to be exposed. They're going to be now peripheral. Because in rouleau, the red cells at the center form rouleau, the white cells are at the periphery. You're going to have now the cells getting contact with the vascular wall. Point number 2 here is that activated endothelial cells and leukocytes have complementary surface adhesion molecules, which briefly stick and release, causing the leukocyte to roll along the endothelium like a tumbleweed until it eventually comes to a stop as mutual adhesion reaches the peak. So initially they are weak bonds. So you attach, you release, you attach, you release, and that way you're activating more adhesiveness capacity. After margination, activated endothelial cells express P-selectins. Once they are activated, the endothelial cells release the P-selectins. These are receptors on the cell membrane, which hook onto leukocytes SLX, sialylated oligosaccharides. E-selectin and ligand for L-selectin. They're not expressed on normal endothelium, but they are induced after stimulation by cytokine 1 and tumor necrotic factor. These are some of the cytokines that are released during an acute inflammatory response. Right? So we have the E-selectin and the ligand for L-selectin being expressed on the endothelium. So we have the leukocytes with the Lewis X modified glycoprotein. We also have integrin. These are activated during this process. And as the fluid volume in the vessel reduces, we saw there's more stasis, and these guys, the white cells start rolling. When they roll, the attachment, because now we have our expression of the P-selectin and E-selectin, then and the proteoglycan, then you have what? A rolling moment, short-term bonding, another rolling, until they come to have a position where there is a tight bonding, and this cell is not going to roll anymore. It's tightly bound now. So it's going to find the space in between the endothelial cells and start the process of exocytosis. And for it to move across, you remember the PCAM, the CD31 must bind tightly also between the cells to allow it to go through that. So that's the story. That's the story of, if you're able to master this, then you're going to be able to walk very narrow routes, because you'll have gotten the basics of transmigration. Key things: they are the ligands on the cell membrane. It's a process where you have the initial activation and rolling process as they bind more. Remember the selectins that are on the endothelial surface, integrin, and finally the CD31. What is attracting them? Remember, they are the microbes. They are being attracted where the microbes are. And where the microbes are is where you have the resident immune cells, the macrophages, monocytes, and lymphocytes that are resident in the tissue. They are the ones releasing the chemokines to attract these guys. So these guys are being attracted by signals from in here. Okay. Of course, they're also attracted by the tumor necrotic factor at interleukin-1 that is being released also by macrophages elsewhere. So that is the gist of the story. PAM adhesion finally comes through the integrin adhesion molecules, and we have seen that in the flow chart. Rolling comes to a stop and adhesion results. Other sets of adhesion molecules participate. Here is where we have the endothelial ICAM, VCAM, activated by interleukins and tumor necrotic factor. We have the leukocyte. On the leukocyte, we have LFA1, MAC1, and VLF4. We have the ICAM, which binds to LFA4, and all these things bind together. Ordinarily downregulated or in an inactive conformation, but inflammation alters this. So normally, these molecules are downregulated or they are not active. But the moment there is interleukin-1 and tumor necrotic factor activation or release, the endothelial and leukocyte adhesion molecules become activated. Normally, half of the neutrophils in the peripheral blood are part of the circulating pool, as half are marginating pool. This changes depending on activating or inactivating neutrophil adhesion molecules. Our key cell here is a neutrophil. Is a key marker of acute inflammation. They're the first line phagocytes that we use. And normally they are divided. Half of them are in the pool where they are active, they are almost activated. But when you have an acute inflammatory response, the bigger component is activated and it goes to the phagocytic mode. So these are the endothelial and leukocyte adhesion molecules that you're going to be able to measure. These are the ones responsible for the rolling and adhesion, and finally adhesion. The adhesion, firm adhesion in the molecules eventually. Transmigration. This occurs after the firm adhesion we have seen through the CD31. Neutrophils migrate through the vessel wall primarily by squeezing between the cells at intercellular junctions. And this occurs within the systemic venules and pulmonary capillaries via the CD31 molecules, or PCAM1. After passing through the endothelium, leukocytes secrete collagenesis that enable them to pass through the vascular basement membrane. This collagenesis basically digests that component of basement membrane and allow the cells to pass through. Early on during inflammation, transmigration involves mainly the neutrophils, but later we have monocytes and lymphocytes joining the drama. That's how it transforms. You know, within 18 hours, they're purely neutrophils. Then you start seeing the monocytes coming in and the lymphocytes, which take over after 72 hours. Because after 72 hours, the neutrophils have done their work and you need to have clearing. And if not so, they are frustrated. They're not able to finish everything. So the bigger monocytes come, transform into macrophages, mop up everything and clean the tissue, allow it to recover. Chemotaxis. Chemotaxis in leukocytes follow chemical gradient to the site of injury. So these are the attractants. So the chemicals that are being released on the site of injury, they are the ones attracting these leukocytes. And the chemotactic mediators that bind to neutrophil surface receptors include soluble bacterial products, complement, cytokines family, the chemokine family example is interleukin 8, and the leukotrienes, arachidonic acid metabolites. The binding causes the release of calcium, which increases the neutrophil mobility. So once the neutrophils bind to these mediators, immediately calcium is released in the neutrophils and they're able to increase their motility. And the motility is going to be following the radar. It's going to where there is concentration. So there's chemical gradient. It flows to where the concentration is for the chemokines or the bacterial products. Process of chemotaxis. These are things I know you've done in immunology, but you are repeating them so that they cement and you get to understand. The leukocytes, they extend pseudopods with overlying surface adhesion molecules, the integrins that bind to the extracellular matrix during chemotaxis. Then during this process, they undergo activation. They prepare for arachidonic acid metabolites from the phospholipids. Prepare for degranulation and release of lysosomal enzymes. These are oxidative bursts so that they can be able to phagocytose. And then there's regulation of leukocyte adhesion molecule affinity as required. So phagocytosis, we'll have a mention or a touch on this. We know it's a multi-step process that consists of 3 steps. Number 1 is opsonization, which is the recognition and attachment of the particle to the ingesting leukocyte. After opsonization, then we have ingestion, which is the engulfment with subsequent formation of phagocytic vacuole. Primary lysosome empty hydrolytic enzymes into the phagocytic vacuole, hence producing the phagolysosome. And finally, is a killing. Killing of what? The bacteria. And sometimes also you have the neutrophil also die. Opsonization. So opsonins attached to bacteria. Opsonins include serum complement 3B, immunoglobulin IgG, the Fc portion, and other proteins like the C-reactive protein. Corresponding receptors on leukocytes. So the opsonins are attached to the bacteria. So it's tagging of the bacteria by opsonins, and they are corresponding receptors to these opsonized bacteria that are on the leukocytes. And these are the FR fragment, FCR fragment. You have the CR1, 2, and 3. And this leads now to the binding of the opsonized bacteria to the leukocyte. So there's recognition and attachment. So these are bacteria. These are bacteria is opsonized, and then these are leukocyte. This is the wall of the leukocyte with a receptor. Once they are bound on the wall of the leukocyte, this is a leukocyte, and then you have the phagocyte membrane zips up around the microbe. So it's going to zip up and then close this. And when it closes, it forms the phagosome with the ingested microbe right there. And what happens after that fusion of the microbe with the lysosome, and the enzymes are poured there, and you have destruction of the bacteria. And these are the killing of the microbes by reactive oxygen species and the nitrous oxide, or nitric oxide rather, nitric oxide. And then degradation of the microbes by the lysosomal enzymes right there. Finished. So that's a process of killing and degradation. And that's what you have seen. We have a longer story there that I'll skip because you're going to read it or you know it. And there you have the rest of the process of the NADP dependent. Some leukocyte defects that we have. You can have defects in the adhesion. So when you have the molecules, subunit defects leads to impaired adhesion. Leukocyte adhesion defect 1, leukocyte adhesion deficiency. Yeah. You can have also abscess of Cialis-Lewis X and defect in E and P selectin sugar epitopes that are on the leukocytes. Once you have these defects, this is responsible for the final binding, tight binding. This is responsible for what we saw as responsible for the, once they marginate, there's a rolling and attachment process and activation. They're also responsible for activating this. So once those are missing, you're going to have defects in adhesion, then defects in chemotaxis or phagocytosis. You can have microtubule assembly defect leading to impaired locomotion and lysosomal degranulation. Example is when patients have cardiac Higashi syndrome. You also have defects of microbicidal activity. So deficiency of NADPH oxidase that generates superoxide, therefore no oxygen-dependent killing mechanism. And this occurs in chronic granulomatous disease because the body is not able to kill the microorganisms. What are the important chemical mediators that are responsible? We have seen now the act of the war. So we are just wrapping up. They are derived from plasma, from leukocytes, from local tissue, and the bacterial product. So these are the chemical mediators. And arachidonic acid mediators are released from the membranes, from membrane phospholipids in macrophages. Endothelial cells and platelets. Remember one thing, these mediators have a short half-life. They don't live for many minutes. Many of them function for seconds. And there's a reason. They are metered according to the intensity of the inflammation. So if there are few bacteria, you do not want the body overshooting, overkilling. So if it's a housefly, you don't need a hammer. But then if it's an elephant, then you need a heavier weapon. And that's how the body reacts. So it releases the mediators according to the level of stimulation or cellular destruction or chemical mediators released by the bacteria. They may have local or systemic effects like histamine causing itching or anaphylaxis. So you may have that coming into play. And they also have other diverse functions. And these are some of the functions that we are going to see. These are some of the mediators. These are some of the mediators and their source and their actions. Like histamine, where it comes from, the mast cell is one of the cells that are so important in the body. Platelets and mast cells are all over. Nitric oxide is from the endothelium and macrophages. The cytokines, mainly from macrophages, endothelial cells, and also the mast cells, and the chemokines. Then you have the plasma protein derivatives. You have the complement system. You have the kinins, proteases activated during coagulation. And those are the important. Good. So we have accomplished our mission. Remember, our mission was to identify the offender. We destroy them. And we have destroyed them. Once you have destroyed them, you need to clear up your mess. Stop the war, declare victory, repair, stop the mess, and go back to normal status. During this destructive process and dilution process, we have what we call the types of acute inflammation. Yeah. What are the different morphologic situations that we got to find? Because the war could be in the sea, war could be in the mountains, or in the valleys, in the flat zones, could be in the city, or could be in the grasslands. Those are the morphologic patterns that we are discussing. So this location depends also on the cause of the inflammation, the duration of the action. The duration of the action, the intensity of the war causes a different morphology. So are we going to find a flattened city, or we are going just to find a few zones that are destroyed? The first one is called suppurative or purulent inflammation. And this is where we have formation of abscesses. Here it's manifested by the collection of large amounts of purulent exudate. This is what we call pus, consisting of neutrophils, living and dead, necrotic cells, and edema fluid. Sometimes we might even find bacterial elements or fragments or some bacteria inside there. But that is suppurative inflammation. And this is associated with abscess formation, where we have focal collections of pus that may be caused by seeding of biogenic organisms into a tissue or by secondary infections of necrotic foci. Abscesses typically have a central, largely necrotic region with a rim of a layer of preserved neutrophils with surrounding zones of dilated vessels, fibroblast proliferation, indicative of attempted repair. The usual outcome with abscess formation is scarring. What happens with time is that the neutrophils and the debris inside, number one, the scarring around it, the attempted repair around it, and this is a process of damming. You form a dam around this debris to protect these bacteria and the phagocytes from destroying and moving on, destroying the tissue. So you zone the area. The idea of the function of the army comes from how the body deals with itself. So you have to understand medicine even to be a good soldier. You dam it off, form a wall around them. Then you bring in the macrophages, and they come and they clear the debris completely. And as the macrophages clear the debris, the dead neutrophils, the remaining bacteria, and everything, then you have a scar formation. The bacteria is gone, the neutrophils are gone, everything is eaten up. You have no more you have self tissue, which is formed a scar around that abscess, which can be remodeled slowly by the body as the days go by. So we have suppurative with abscess formation. This part of our brain, this part of the brain, and what you see, this purulent exudate. Okay, purulent exudate. So you are going to have this abscess finally walled off. This debris will be eaten up. And in the brain, you usually left with a cystic space because we don't have new brain capability of proliferation, and we don't have significant fibrosis in the brain. Usually we don't have much fibrosis in the brain. We don't have that capacity. So what happens is that you remain with an empty cavity, which we call a cyst, post the abscess formation in the brain. We have the second type, which is called fibrinous type of inflammation. And this is due to severe injuries resulting in greater vascular permeability that allows large molecules, such as fibrinogen, to pass the endothelial barrier. Histologically, the accumulated extravascular fibrin appears as eosinophilic meshwork that threads, or sometimes meshwork of threads, or sometimes as an amorphous coagulum. So this severe injury occurs mainly over the serosal lining of the pericardium, peritoneum, or the pleural cavity. And this poses a big danger of adhesions between the parietal, and the visceral pleura, for instance. And those serosal linings, once they attach each other, they adhere, you're going to have a what? You're going to have serious consequences, because naturally the two surfaces offer allow for movement of the organ and the wall without friction. So here we have the example. This is the pericardium, fibrinous pericarditis. Here you have the surface of the heart, and here we have the pericardial surface, pericardium. And you have this brownish fibrin deposition right there. On the photomicrograph, histology, then you have this pinkish material here, which is fibrin, the pink meshwork of fibrin here. Yeah, this is a pericardial wall. Yeah. So you have this meshwork of pink fibrin with a mixed scattered inflammatory cells in between. So this is very exudative. It really pours a lot of fibrin, and this occurs in acute severe inflammation where large particles can enter into that cavity. The third one, which is very common, is serous inflammation. And here we have thin, watery exudate. Insufficient amount of fibrinogen are produced to produce any fibrin. An example is blisters. We see blisters in second degree burns. We see it in viral infections, like even herpes labialis on the lips. We see herpes with little blisters. We see it a lot in immunobullous disease. Immunobullous disease, yeah, the pemphigoid and pemphigus groups, we see that a lot. So here is an example of a blister. And when you look at it under the microscope, you see the accumulation of fluid right here between the epidermis and the dermis. Sometimes it's cell poor, other times it's quite inflamed, but that is a serous type of inflammation. And I think we are done. We have seen abscess formation, we have seen purulent, we have seen fibrinous, and now we have seen serous. Good. So now, how do we stop this inflammation? So what factors are involved in the termination of inflammation? Number one, we have the short half-life of the inflammatory mediators. We talked about seconds. Some of them are produced in seconds or milliseconds, and they are released in batches. So you have a release, the neutrophils respond, there's phagocytosis. Do we have any more opsonized bacteria? No, the stimulus stops. So actually you have a pause to the process of acute inflammation. Once this occurs, then you have switch from the pro-inflammatory cytokines to lipoxins, which are anti-inflammatory mediators. These lipoxins are derived from arachidonic acid metabolites. Example is lipoxin A4 and leukotriene A4 and B4. Then you have, they inhibit transmigration of the leukocytes and chemotaxis because you don't need more leukocytes. And you also now we have signal macrophages to phagocytose apoptotic bodies. Thank you very much for your presence. Yes. Here is where we have a change. Pro-inflammatory, we have two types of macrophages. We have M1 and M2. Please take your time this evening and look at the macrophage. We have type 1 and type 2. So M1 is pro-inflammatory. Is the one that was involved in those early releases of the interleukins. Now we have type 2 macrophages coming in, And when they come in, what they do is that they clear the debris. They clear the debris and they initiate the process of healing. They initiate the process of healing, vascular regrowth, endothelial regrowth, all those things now. M2 comes into function. Then you have resolvins. These are synthesized from omega-3 fatty acids. And they do what? They inhibit production and recruitment of inflammatory cells. And finally, we have seen the clearance of neutrophils by apoptosis. By who? By the M2 guys. So the mopping has occurred and the body switches off from a war to peace. Yeah. The macrophages, what are the apoptotic bodies? The apoptotic bodies, actually, they're already, as you see, yes, there's a programmed cell death. These are the cells that have done their function. Once they have done their function, they are no longer necessary, so they are dying. But that debris remains. It has to be taken away. Yeah. Even after normal apoptosis, when the cell dies, it has to leave that area and disappear from your body. Otherwise, our bodies will be full with dead cells. Remember, most of our cells, like the mucosa, the skin, most of our cells in the body, in the mucosa, they fall off into the GIT. So they are digested again and reabsorbed. From the skin, they fall off to the ground. And that's why if you stay for 2 years without shower, we are going to get thicker skin because you may retain some of the keratinocytes. What about the cells inside the tissues? They have to be mopped up, and that's where the macrophages come. They come clearing. And I think we are through. Don't you think so? Okay, we still have a few minutes. So what are the consequences of acute inflammation? You got to pay for this war. It will cost you money. It will cost you death of innocent civilians. The infrastructure will be damaged, okay? Number one is complete resolution. So you're going to, one of the best outcomes in this war, which probably you did not even cause yourself, is that you're going to have a return to normalcy. So when there's mild injury to the cells, you can have regeneration, complete regeneration. And this occurs largely in labile and stable cells. Yeah, so mucosal tissue is going to regenerate completely. And stable cells, they're also going to regenerate. Remember about the liver, you can lose up to half of the liver and still regenerate itself, as long as the remaining liver is healthy. If you have liver cirrhosis, then you cannot have complete regeneration. No way, because the primary tissue is not in a health status. The other consequence is tissue destruction and scar formation, which occurs when there is extensive injury or damage to the permanent cells. That we understand. And then we have formation of abscesses. You can have huge abscesses forming inside the muscles, inside the, lung abscesses, which could move into pleural abscesses, all those, in case you have extensive inflammation like in bronchopneumonia. If the offending organism is not cleared in the early phase, like tuberculosis, foreign bodies like, silica, leprosy, then you're going to have transformation or progression into chronic inflammation. These are places where you're trying to kill, but you can't. So you have now the role moving to transformed macrophages, which we call Langerhans cells. And the Langerhans cells come in, the epithelioid cells, and they take over. And our duty is done as acute inflammatory operators. Thank you very much. We can pick more. Thanks for the reactions. We can pick more from it and see what we have. Okay, make sure you go. Thank you, everyone. Make sure you go polish up acute inflammation. There are little gaps there. We skipped a component of phagocytosis because I know it's something you do in immunology. Important. Do viral infections have polymorphonuclear invasion or monocytes? Every acute inflammatory response, viruses, TB, the initial phase is always going to be neutrophils. They come in and they are frustrated. They don't find they have a function, and quickly it shifts to monocytic invasion. So by the time we're coming to describe it, actually we have a lymphocytic, but actually the people who pick it from the initial, it always starts as an acute response because the acute response is not triggered. It's stereotyped. Is always stereotyped apart from one. And this particular one is acute graft versus host rejection. This one is going to be purely lymphocytic. Okay, that's a good question. It's all, and so that's a caveat. Very important. And if someone else may ask you this, then you need to understand how you respond to it, because acute inflammatory response is a stereotype response to any form of tissue damage. So it's programmed like that. Initially, it will always going to be vascular and cellular, and the cell of acute inflammation response is always going to be the neutrophil. You're never going to have the invasion of the land from inside. It's never going to trigger the marine. The marine is not going to come to fight in dry land where when the army is present and not overwhelmed. I hope that makes sense. Thank you very much. We can finish. There being no other business, please don't waste the time. Go invest it in another way to finish up and put the gaps. Remember, these just maybe 20% of what you need.
Thank you.